Thank you very much, ladies and gentlemen of the press, citizens of Kenya. This is a press statement following the full council meeting held at the Lake Naivasha Swela Lodge in Nakuru County today. The Council of Governors today convened an ordinary council meeting to conduct elections for the position of Council of Governors Vice Chairperson. The elections were conducted in accordance with Section 19.3 of the Intergovernmental Relations Act Cap 265F. The governors unanimously elected His Excellency Muthomi Njuki, Governor of Tharaka Nithi County, as the Vice Chairperson of the Council of Governors. Following his election as the Vice Chair, the position of Whip fell vacant. Governors subsequently elected His Excellency Benjamin Cheboi, Governor of Baringo County, to serve as the new Whip of the Council of Governors. In addition, the Council has commenced a two-day symposium to deliberate on and develop a unified county government's position on two major national programs. One, the Affordable Housing Program, AHP, and two, the Social Health Insurance Scheme, or SHA if you like. These flagship initiatives have significant operational, legal, and fiscal implications on county governments, and the Symposium aims to provide clarity, consensus, and strategic guidance on matters health. Number one, delays in claims payment by SHA. 14 months into SHA implementation, outstanding claims have reached over 10.5 billion shillings. These prolonged delays in claims payment or reimbursement negatively affects counties' creditworthiness and limits their ability to honor suppliers' payments on time. Therefore, SHA claims be paid or should be paid on a timely and predictable manner to avoid disruption of essential services. Two, on rejection of SHA claims. There is an increase in rejected claims, which currently stand at 10.4 billion shillings for public and private claims, with no appeal mechanism in place for claims when rejected by SHA. The Council therefore urges the Minister of Health to urgently develop an appeals or redress mechanism, including operationalizing the Dispute Resolution Tribunal, which is envisioned in the Social Health Insurance Act. This matter is very, very critical because it serves as a disincentive and a demotivator to the healthcare workers as well. When under FIF, they work and treat patients only to be told a huge percentage of the services they offered will not be compensated or indemnified in line with the SHA policies. then SHA ceases to be a fair insurer. 3, on the directive by the Medical Council on level 2 health facilities, level 2 and level 3 health facilities, which directive is affecting SHA claims. The directive by the Ministry of Health to stop maternal services with respect to deliveries at level 2 facilities has reversed the gains made in improved maternal and perinatal outcomes, especially in rural and ASAL, arid and semi-arid lands counties. The Ministry of Health should immediately, as agreed previously, because we had an agreement on this, should immediately rescind that directive to guarantee access to maternity services at level 2 and 3 as provided in the SHA maternity benefits package and pay for the services. Counties have an ambulatory service which is integrated with their hospital system. And this is why it's vital to allow deliveries at level 2 for normal deliveries. And as and when we suspect a delivery is assessed as a difficult or emergency, then the ambulatory system kicks in and delivers that mother to the nearest sub-county hospital. We have actually lost mothers in the process of trying to transfer them from a level 2, which has turned them down, to a level 4 when they could well have been helped at the level 2. And there were cases here of counties that have actually experienced a rise in maternal deaths as a result of this extremely impulsive decision that was taken by bureaucrats at the Ministry of Health, which was really uncalled for, if you ask me. 4th, access to SHA services by county staff. County government staff find themselves locked out of medical services, and this includes even healthcare workers, forced to pay for healthcare services out of pocket, even though the deduction on salaries would still be done upon payment. And this is because SHA has adopted a policy that if you don't pay premiums by the 9th of the month, you lose coverage for that entire month, regardless of whether you pay those premiums by the 10th of the month or the 11th of the month. The Council calls upon SHA to allow county employees to receive uninterrupted service, since remittance would still be made within the month in most cases, or within the fiscal year after disbursements by National Treasury. Why counties delay in meeting these deadlines of SHA is because of delayed disbursements by Treasury and the onerous process of release of money also from the controller of budget. In any case, SHA also takes months to reimburse us. So it's not fair to lock out employees when they themselves are not meeting their part of the bargain, which is to pay our reimbursements and our claims by the 14th of every month. Fifth, on the rollout of SHA ambulance services, Schedule 4 of the Constitution of Kenya designates ambulance services as a devolved function. Several counties, nearly all counties I would say, have existing ambulatory systems and structures that SHA can just decide to implement a parallel ambulance service open to everyone on a Uber-like scheme without as much as discussing with the Council of Governors, clearly steps on the mandate of county governments. SHA should therefore immediately engage the Council to review and harmonize the rollout of whatever ambulance system they have in mind. That the ambulance services should be expanded to also include inter-facility referral services. We had made this very clear that the ambulance system that they are thinking of rolling out for emergency services should be done in consultation with county governments so that we have a way of fitting existing county ambulatory services systems into whatever new arrangement. And this is why Article 6 of the Constitution constantly, we've raised this, has made it mandatory that the two levels of government engage on the basis of mutual cooperation and consultation. That's in as far as health and SHA is concerned. Moving on to affordable housing, the Council, together with the Ministry of Housing, State Department of Housing rather, and the Affordable Housing Board have discussed conclusively and agreed on matters relating to affordable housing program for onward submission of the same to the summit, which hopefully comes up in the next 2 weeks. This was a pre-summit meeting to iron out issues around affordable housing, from matters, provision of basic services in the housing estates, to processing of sectional titles for buyers of those units. And we have agreed on all the matters which the governors wanted discussed. The Council, therefore, is hopeful that the summit will adopt the outcome of the discussions that we've had today. Last but not least, the Council further held a consultative engagement with the Mission for Essential Drugs and Supplies, MEDS, and PATH, two key health sector partners of the Council of Governors. The discussions with MEDS and PATH centered on improving supply chain efficiency, strengthening service delivery, and expanding partnerships that enhance county health systems. Asanteni sana. Mungu awabariki. Signed, yours truly, Ahmed Abdullahi, Chair, Council of Governors. I don't expect many questions, but I can take one or two. Hata naona hawana maswali. Mungu awabariki.